We have one more session from a young, good-looking lady. We now turn to a gray-haired, older gentleman by name Dr. Ramakrishnan, my good old friend. He has presented here once before the importance of hypoglycemia in clinical medicine. We have had any number of lectures or classes dealing with hyperglycemia. Nevertheless, the hypoglycemia factor is often overlooked, and today, with a large number of drugs, many patients come to the outpatient or casualty department suffering from hypoglycemia. I don't want to prolong this introductory remarks. I call upon Dr. Ramakrishnan to deliver his address.
Thank you, Paul, for the kind introduction. At the outset, let me confess that I stand before you not as the Jesus of diabetology, but only as a Moses. And my attempt is only to refresh your memory, because all of you know about the topic which I am going to talk. Actually, this was prepared for an undergraduate speech, but unfortunately, it had to be included here. All of you know that diabetes is a science for researchers, boon to the industry, problem for the physician, and catastrophe to the patients. You see the burden, I need not explain. This is the goals for glycemic control as on now, but there are certain differences because American says now this SB1C should be can be between 7.5 to 8. So some differences of opinion because between Indian diabetologists and American diabetologists. Diabetes mellitus today, we have got more insight, more drugs, especially OHs, designer insulins we have got, and novel devices, both for diagnostic and therapeutic purposes. And among the patients as well as doctors, there is more awareness. Yet, normoglycemia remains a dream. Why? That's the most important question. Hypoglycemia, this is the whole truth. Why normoglycemia becomes a dream is because of a subject called hypoglycemia. Most of us think what we think about hypoglycemia is a blood sugar about less than 50 gram. That finishes our talk on hypoglycemia. But most of it you know, but some you may not know. That I am trying to fill in the blanks. This is the question. Hypoglycemia, is it an orphan? I definitely agree with this. Hypoglycemia is still an orphan when you compare with hyperglycemia. Every diabetic suffer from hypoglycemia. Who is the villain? Is it the doctor? Is it the disease, drugs, or the patient? It's a very important thing to discuss about. Hypoglycemia, why it matters? That's the most important thing. Incidence of diabetes is increasing. Tight control is a watchword. Multiple drug regimes are there. Early initiation of insulin is the watchword nowadays. And expanding use of insulins in type 2 diabetes is again a reason. Why hypoglycemia matters? When you talk about hypoglycemia, the definition is it's a biochemical term, plasma glucose below 50 milligram, or it should satisfy Whipple's triad. Symptoms, a blood glucose of less than 50 and reversal of these symptoms with the administration of glucose. This is a classical definition of hypoglycemia. Now, classification. This is the recent classification. You don't find it in the Indian textbooks, but if you go to American textbooks and other things, you will find, I need not explain it. It is well explained. Lack of time, I'm not going into all these things. Now, what is the normal difference? When the glucose goes up, naturally the insulin also goes up and becomes normoglycemia. When the glucose comes down, hormones like glucagon, epinephrine, growth hormone and cortisol goes up and again makes it normal glycemia. This again. Now, how common is hypoglycemia? Episodes not always perceived. Patients records unreliable, variable relationship to blood glucose levels. There is retrograde amnesia. People forget about that they had an episode of hypoglycemia. Emotional denial, even the patient may deny it. And biochemical hypoglycemia naturally occurs during this time before lunch, supper, and around. Now, symptoms I need not broadly to autonomic and neurohormonal. I need not elaborate on the symptoms. All of you know about it. There are some non-specific symptoms. Again, I need not explain all these things. Now, these are the risk factors of the for developing hypoglycemia. Risk factors, relative or absolute. Again, this is all you know about it. I just go through it. Now, factors affecting symptom complex. That's very important. A patient who had an episode of hypoglycemia, that is antecedent hypoglycemia, will have an effect on the succeeding period of hypoglycemia. Posture is very important. Patients who develop hypoglycemia in the standing posture will have more symptoms than a patient lying down. Medications, patients are already on hypnotics, alcohol, impair their perception. Caffeine augment the perception, whereas beta blockers, most of the diabetics are now on a beta blocker, they can modify or delay the onset of hypoglycemia. This again, very important thing, subacute neuroglycopenia, which is entirely variable symptoms, individual patterns, premonitory symptoms of hypoglycemia is abbreviated or absent, and automatism, very important thing to be looked into, and it has got medico-legal complications. But the whole target, we always think that of hypoglycemia is brain, but unfortunately it is not the only target. We have got many more targets as far as hypoglycemia is concerned. Now you look at the effects of hypoglycemia on the peripheral blood. Nobody is thinking about its effect on peripheral blood. Go through it, increased white blood cell count, neutrophils all increases sedimentation, hematocrit, blood cell count, increased hemoglobin concentration, reduced plasma volume, increased red cell aggregation. All this will have tremendous effect on the effect of a patient with hypoglycemia. These are some of the short-term effects. Cardiac vascular effects. Nobody thinks about cardiovascular effects of hypoglycemia. Increased heart rate, widening of the pulse pressure, increased cardiac output, increased cardiac output. See, then go into the microvascular effects of hypoglycemia. It's a principal pathogenic factor, especially chronic hypoglycemia. Established microvascular disease is vulnerable to an attack of hypoglycemia. There is a profuse secretion of vasoactive hormones, profuse. It reduces the capillary flow, causes stasis of the capillaries and closure of the capillaries, and thrombosis, ischemia, or hypoxia. Many studies have supported these factors, and nocturnal hypoglycemia can cause even vitreal hemorrhage and decrease the renal plasma flow and reduce the GER. Now look at the cerebral events. There is decreased concentration, drowsiness, loss of consciousness, mood changes, irrational or aggressive behavior, denial of hypoglycemia, again automatism. Automatism, I don't know what do you mean by automatism. Dr. Ajit can say, we had one patient, a very popular, prominent figure of Cochin. He used to play cards in the club room, and one day I got a frantic call stating that somebody is doing something. I was the president of the club. When I went there, I saw him unstrip his what do you call button pants and pissing in front of all the people. He doesn't know what had happened. But since he was my patient, I knew this was a chance, and we took him to the hospital. The blood sugar was 35. So automatism is a very important thing which none of us think about it. We think that it is all due to alcohol or any other intoxicating substances. Physical injury is very common. Small falls in the house and other things we never attribute it to hypoglycemia. But many diabetic patients, all these falls and other things can be due to hypoglycemia. Skeletal injuries, falls, dizziness, incoordination, drowsiness, loss of consciousness, and even convulsions and road traffic accidents, which I will come later. Now, it affects the quality of life. There is an impact on everyday activity. It may be unpleasant and frightening. It can cause chronic anxiety and depression, phobia, equal to complications, affect self care and self management, and encourage poor suboptimal control. Once a patient experiences hypoglycemia, then he will be always be careful and may even reject or omit some of the drugs so that he may not get an attack of hypoglycemia. Now, mortality with hypoglycemia estimation is very difficult. It can precipitating acute hypoglycemic attacks are often overlooked. Sudden death, many of the sudden deaths may be due to hypoglycemia. Again, that is overlooked. Dead in bed syndrome, or it can cause cardiac arrhythmias. Many of the deaths of diabetic patients at night and other things may be due to a cardiac arrhythmia because of undetected hypoglycemia. What can we do about increase awareness among the patients, avoid therapeutic jugglery, advice to the patient, right advice to the patients about hypoglycemia, regular snack at night, timing of the food and drug should be modified according to the patient's occupation, exercise. So many people exercise in the night, evening, and other things, over exercise, and such people may get a hypoglycemia at night without their knowledge. So their food timings has to be improvised depending upon the individual patients, and avoid patient physician errors. This is the most important thing I feel. Just have a look at it. See physician's errors, therapeutic greediness, I would say. Just see a prescription, Amaryl 3 times a day, 3 milligram 3 times a day. We call it as therapeutic greediness. Then again see a prescription, Levemir 10 at bedtime, Novomex 4 twice a day, Amaryl 2 milligram 00 half, Melmet SR 1 gram 101, Januvia 100 milligram 100. This is for a patient with 75-year-old with other comorbidities. And again, look at this. This again a 78-year-old patient, a prescription, Glimepiride M2 110, injection Mixtard 30/70, 50/50/14, injection Basaglar. Yeah. This you can know on the slide. Glimepiride 110, Mixtard 50/50/14, Basaglar at bedtime, then Sita. All these things you just see in a patient with 78-year-old patient. Imagine the insulin dose 50/50/14. This is what we call a therapeutic greediness, and maybe I feel that one of the most important causes of hypoglycemia. This is a very important statement. Insulin is a remedy primarily for the wise and not for the foolish, whether they be doctors or patients. Very important message doctor has to know. Everyone knows it requires brains to live long with diabetes, but to use insulin successfully requires more brains. Again, a message to the doctors. Now, treatment, I know I don't want to talk about treatment. This is again very important. Nocturnal hypoglycemia, 50% goes unrecognized. Important cause is hypoglycemia unawareness. So, very important to prevent nocturnal hypoglycemia. This is how we should prevent nocturnal hypoglycemia. Again, the treatment, you know about it. I need not go further. This is again an important aspect of hypoglycemia. Hypoglycemia unawareness. This is the inability to consciously perceive or discern the onset of hypoglycemia. It is very common but often goes unrecognized. It can have devastating problems. There is no fixed level of awareness in 20 to 25% patients. This is maybe probably due to the failure of the ventromedial hypothalamus. These are the clinical situations of hypoglycemic situation. Long duration of diabetes, they can have this. Possible mechanism is unknown. Perhaps repeated hypoglycemia, damage to the glucose sensitive neurons. Tight metabolic control. Now there's always we think about tight metabolic control. This can be caused, and alcoholic ingestion can also cause this hypoglycemic unawareness because it suppresses the autonomic peripheral responses like tremor and impaired cognition. Again, nocturnal episodes, sleep preventing recognition of early symptoms, and supine position impairing sympathoadrenal responses. Children and elderly, prominence of impaired cognition, possibly of reduced autonomic response and reduced adrenergic sensitivity. These are some of the management strategies. Don't go for this low 6 to 7% HbA1c as theoretically said, multiple glucose blood tests, strict targets, and nocturnal blood glucose estimation, and insulin analogs and flexibility. Now, some of the future prospects for glycemic unawareness, caffeine can prevent this, cortisol antagonist or intermittent low dose metronidazole can be a treatment option for preventing this. And beta blockers, those who are on beta blockers, it is said that they don't develop this sort of hypoglycemic unawareness. This is the most important thing. This is so many driving accidents are happening here, and you know that so many young patients are taking anti-diabetic medications, which is a recognized cause for RTA, main cause of non-fatal accidents. Statistics O is often underestimated, which is alarming. Most did not experience hypoglycemic symptoms at the time of exercise. It features resemble alcoholic intoxication. Even after every accident, police checks the blood alcohol level, but not the blood sugar level. This is an important thing. In many foreign countries, now I'm told that driving licenses, if they are diabetic, they should have a card along with them. You know how it causes driving, interfere with the driving skills, cognitive dysfunction, especially even at the low level of blood glucose, judgment, insight, all impaired, road positioning, and inappropriate braking, visual information processing, all these things are happening because of hypoglycemia, which goes unrecognized. So the advice you have to give as a patient when they come, don't advise on diabetic medications alone, but advise them also to have a safe driving pattern. Do not drive if eyesight deteriorates suddenly. Check blood glucose before driving, even on short journey and at intervals on longer journeys, especially longer journeys. You engage a driver whose diabetic or the health status is not known. You start at 6 o'clock or 5 o'clock in the morning, and by 10:30 or something like that, the driver may have a hypoglycemia, and it can cause accidents. Take frequent rest with snacks or meals and avoid alcohol. Keep a supply of fast and longer acting carbohydrate in the vehicle for emergency use. Carry personal identification to indicate that you have diabetes and are prone to hypoglycemia. Hypoglycemia develops, stop driving, switch off engine, leave the driver's seat, and then treat. Do not resume drive for 60 minutes after blood glucose has returned to normal. Because nowadays we are hearing many accidents occurring at early morning, 3 o'clock, while going to airport or something like that. And most of them may have diabetes, 60-year-old, and I think this goes unrecognized. So to conclude, hypoglycemia is a common symptom with long-term consequences. Recurrent episodes, hypoglycemia-associated syndromes, aggravates macro and microvascular disease, affect the quality of life, even of the relatives. Suppose you have hypoglycemia, your entire family is also disturbed. It's a preventable tragedy. Never dismiss as unavoidable nuisance. Hypoglycemia, just believe it. Hypoglycemia is not a number; it's a life sentence. So it's very important not to disregard hypoglycemia. This is the most important thing. Management of diabetes mellitus include those of hyperglycemia and hypoglycemia also. Ketoacidosis may kill a patient, but frequent hypoglycemic reactions can ruin his whole life. Nothing is more fatal to health than overcare of it. This is what Ben Franklin has said. Thank you very much for your patient hearing.
Thank you very much for the observation and advice regarding hypoglycemia. I'm sure there will be a lot of questions from the floor. We can't have too many questions. Nevertheless, I invite a few questions.
Thank you, Dr. Ramakrishnan. An exhaustive talk. In a very short while, you highlighted most of the points, which are very practical. A few points I would like to add probably. Nocturnal hypoglycemia produces nightmares. So any diabetic complaining of nightmares, think of nocturnal hypoglycemia. This is one point. As you said, driving and all those issues are there. And also in the older diabetics, above 65, 70, it's very important not to use long-acting drugs. Like you said, Amaryl or Clemiperide. Long-acting drugs are very, very dangerous. And in the bargain, you try to keep the HbA1c below, say, 6.5 or even 7, and you may lose the patient. And especially if the patient has long-standing diabetes and autonomic neuropathy, none of the manifestations, the classical manifestations of hypoglycemia, will not occur. And they just pass to a low blood sugar and die in the middle of the sleep. So autonomic neuropathy leads to masked hypoglycemia. And in Mumbai, years back, there was a fashion among medical students, nurses, and doctors. The way to commit suicide, when they want to commit suicide, the best method they used to do is that take a large dose of beta blocker, propranolol. After an hour, take about 100 or 120 units of insulin. That was proved to be the best way to die without any problems. No convulsions, nothing. So when I was teaching the students about this, I said beta blocker, then large dose of insulin. Some of the students after the class came and wanted more details. How much propranolol, how long, and how much insulin? I got scared because the discussion was going in a different way. You don't know, some of them may be having depression. Anyway, so the long-standing diabetics with autonomic neuropathy, it is better to avoid any long-acting drugs. And we have a funny situation in India. We have a beautiful short-acting drug, very commonly used, glipizide. And people have made long-acting glipizide, which is stupid. The advantage of glipizide is short-acting before every meal. And many a times people stress a lot on single dose advantage. I think practically in a 70-year-old man, what is wrong in taking 3 tablets of short-acting drug or insulin before each meal? What is that advantage of single dose? In the bargain, you are actually creating hypoglycemia, particularly in the middle of the night. This is one point we practically see. So better to avoid long-acting drugs, thinking that it is convenient. In the bargain, you're actually producing a lot of problems. Thank you. Yes, yes. Underused.
Put one this thing. Mostly we see the hypoglycemia usually 40 or milligram or below. But we have seen patients when they start this getting this hypoglycemia, when we ask to check the blood sugar, it is about 70 or 75, something like that. In such cases, are we really justified in again giving them glucose, or what is your opinion on that?
Yes, I told you the difference is symptomatic hypoglycemia, relative hypoglycemia. Yes, when a blood glucose falls from 200 to 160, they may feel hypoglycemic symptom, relative hypoglycemia. So wait for it. And when you treat hypoglycemia with glucose and other things, the blood sugar may shot up. So immediately don't try to bring down that blood sugar. Let that blood sugar be there for some time, then slowly bring it down. Otherwise, repeated hypoglycemia will occur.
In fact, severe hypoglycemia has nothing to do with the value. The number is immaterial.
Yes, yes.
Severe hypoglycemia is defined as any hypoglycemic spell where the patient requires another person's help. That's all. It may be 40, it may be 70,
Yes, yes, yes.
depending on the duration of diabetes and the general condition of the patient, his glucagon levels, and many others. One more point, apart from the antidiabetics, potentiation of hypoglycemia happens even with quinolones,
Yes,
quinolones, quinine. So we have to keep in mind that these drugs also can potentiate the chances of hypoglycemia.
That's correct. One more point, I don't know, that's for opinion from you all. Nowadays, we see a lot of advisors, especially after cardio surgery and other things, 7-point blood glucose estimation. But they have advised only 3 times small dose of insulin. Then what's the point in having 7 point? 3 a.m. also you have to check the blood sugar, the thing. And such patients, I have had some few patients comes with hypoglycemia, then hyperglycemia, then hypoglycemia. So I don't know why the 7-point program mostly seen from cardiological centers. I don't know the rationale behind it.
One last advice is when you are confronted with a case of hypoglycemia, and when you treat that, immediate response is there. But always never forget that hypoglycemia can last much longer. So be aware and be close to the patient and watch his blood sugars for several, at least for a few hours after the primary incident. I do not want to, prolong this discussion. We can have several sessions.
My humble advice is that don't overtreat such elderly patients, 75 and other things with comorbid conditions. Don't be greedy to make their blood sugar like a young person. So it can have deleterious effect as far as my 40 years practice is concerned.
Thank you very much for the excellent. Thank you very much, Dr. Ramakrishnan.
Thank you, Dr. Priya, for the excellent presentation on constipation, and Dr. Ramakrishnan for the excellent presentation on the hypoglycemia, and Dr. Paul Putran for the excellently chairing the session. Now we will go on to the next this thing. I invite Dr. Ajay Kumar K to present a memento to Dr. Priya. I invite Dr. Ajay Balakrishnan to present a memento to Dr. Ramakrishnan. I invite Dr. Srinivas Kamath to present memento to Dr. Paul Puthuran. Thank you. Now we